for me, is something I've learned over time, especially interacting with quite a number of my friends that are going through the journey of trying to get children. So I think for me, that was the first element, that no one ever sat me down and told me, actually, there's a possibility that you might not.
Didn't even occur to the guy that there can be a possibility that there's no sperm. You have an 11% chance of getting pregnant a month, usually 11 to 15%. A guy who gets gonorrhea, you will know because you will be on fire when you're literally
Burning.
It is just burning, and you cannot stay at home with gonorrhea.
We're captives of our own identities, living in prisons of our own creation.
This is Filling the Gap podcast, where we are seeking to fill the gap on what your doctor and your mother didn't tell you. My name is Dr. Muchiri. I'm a consultant obstetrician and gynecologist, a fertility and menopause specialist, and this is Filling the Gap. Today, I've got one of my very long-term friends, and I'm excited that this podcast is getting quite a couple of men as well, because these conversations involve both men and women. So on today's episode, we've got Matiko.
Yeah.
I will not introduce you so that you say all the big things that you're doing, how we are friends, what, and all the stuff that we get to do together. So, over to you.
Okay, so thanks, Dorcas. So I'm Dr. Matiko Riro, medical doctor. Of course, I've known Dorcas for a very long time from medical school. And over time, got to do a lot of many things. Then we've been meeting in all other places to talk about these things. So currently I'm the CEO of Savannah Global Health Institute, an organization that is working to strengthen health systems across the continent. And for this conversation, in terms of some of the things I've been talking about around the challenges on women, so I find Dorcas to be one of those people that sort of anchors me on some of the thoughts around how to think about women health. So I'm really happy to be in this conversation.
Good. So health systems, what is that? How would you define that for our audience?
Oh yeah, so basically by the time the patient is being seen by the doctor, there are so many other things happening to facilitate that. So you'll have to imagine you get into a hospital. There's a way the medicines reach there. There's a way that doctor actually got there because there are other people to pay for that. There's a way that building actually exists in that whole place. So that whole essence of facilitating this, there are many layers that could be within that county, but even beyond the county, at the national level, there are many other things happening. And even globally, there are global interests around certain things of having to access. So how all that system is built to result to that care being given. We're working to basically help move those cogs that get the health care being delivered to that patient.
Okay.
Yeah.
So your work is in improving these health systems.
Absolutely.
Okay.
Yeah.
All right. Yeah. So for our audience, this is a good chap to know, because especially for women's health, we know that there are many gaps, and like you said, the cogs, sometimes some of them are moving and some parts are not moving, and that's how our work sort of intersects.
Absolutely, because there is one thing about the care being given, but even the women themselves making decisions to go seek that care is a whole part of the system. Even them getting there is a whole part of the system. Then people being ready, the hospital, the facility being ready to provide that care is part of that system. So walking through that journey is something that we're very keen on.
Okay, good. So today's conversation is interesting because it's one of the places, or one of the conversations that I feel has some big gaps, and the podcast is Filling the Gaps. And you've talked about healthcare access, and we talk about equality and things like that. So this area is of fertility, and I feel like a lot of focus has been put on big things, which cause death, maternal deaths, and a lot of work around mortality, which is death rather than morbidities, and fertility. And some of the work that I do is very neglected. What do you think of these areas? So what's your experience with this?
I think my experience, especially around women health, and especially as we talk about, strengthening health systems, sometimes we tend to go to the part, to the one you have to imagine that these are leaking taps. So you many leaking taps in the house. So you tend to go for the one that is leaking the most, right? Of course, you can argue then you keep on neglecting the others that also need to be paid attention to. So we've probably disproportionately or fairly so sort of focused on the bigger taps, mostly around how do we get mothers walk through the pregnancy journey and deliver safely and have a live mother and a live child, which I think is a fair thing for us to do. But I guess that should not in any way get us not forgetting that there are many other challenges that we're looking at. And sort of sometimes we've shaped systems to be more around death. Let's prevent deaths, which I think is a fair game. But again, how do we, certain conditions do not necessarily result into death, but they have emotional and other socio-economic implications if we don't get into that. And I feel like aspects like fertility then play in this zone, that they're not, to a certain extent, it's easy to forget because then they don't result in mortality, especially in a setting that does not have a lot of resources that need to prioritize and say, let's go to this area.
Okay. So in thinking about fertility, are you a dad?
Oh, yes, I am. Yes, I'm a father of 2 kids, a boy and a girl. 11, the girl 11, girl is turning 11, and the boy is turning 8. Probably around mid this year.
Okay.
Yeah.
How are you finding fatherhood? How has it been?
It's a very interesting question because it's I think I can answer it from so many perspectives, especially from the time when we got the girl, which is almost 11 years ago. I'll ask the same question, like, I think this friend of mine called me aside, looked quite concerned, and said, so you're going to be a father. How do you feel about it? Honestly, I was like, this is like something that should happen, because especially when you grow in a society that you've seen this happen so many times, there's a way, you don't even overthink it. I find like when you've not probably grown in a, for me, of course I have to give it away. I grew up in a village where there are a lot of emotions attached to like a baby's coming, because they come. Why should you be thinking about how they are coming? So at that point it's different. And then having walked the journey for the many years, I think it's the anxieties around it. How do you get the best out of them? How do you give the best? And what does that best mean? I think for me, the fatherhood has been just those anxieties of how do we get this happen? But sometimes you've got to sort of relax on yourself based on the fact that I think I've seen so many people walk this journey, and of course interactions with other people, seeing how they're doing it together best. Because again, trying to look at the context of how I grew up is different from now how they're growing up. Seeing how best then can we work around this.
So before baby number 1 came,
yes.
And you grew up in a village,
how
much did you get from your mother or your doctor about preparing? I feel like you've alluded, sort of slightly that where you came from, if you want to give away where you've come from, your village, was there anything like that, like preparing for getting a baby before it even happens?
No, actually, I think for me, the worry I have, especially around, even before preparing, there are a lot of assumptions made, especially young men, both men and women, that all of you is a fair game. You can make a girl pregnant, the girl will always get pregnant. So no one ever thinks about the possibility that might not happen. And I think that for me is something I've learned over time, especially interacting with quite a number of my friends that are going through the journey of trying to get children. So I think for me that was the first element, that no one ever sat me down and told me, actually there's a possibility that you might not, and the girl you get married to might not. So those possibilities are things that we never actually walked through. So then we get in. So here we are. We don't know whether we will, but we hope we will. And then you come to learn other things around, yes, getting pregnant is another, but actually sustaining this pregnancy all through the 9 months and actually coming out alive is a whole other dynamic, especially in certain settings. So that's a whole other anxiety that I come to learn later. But at that time, so like,
Just going with the flow.
yeah, she's
It will
pregnant.
happen.
Let's prepare 9 months later. We'll get, or here I am, I've just gotten married. Said I do. Kids are coming. And this is the number we're going to have. Yeah.
Coincidentally, 1 in 7 couples across the world, I think that's even changed now, 1 in 8,
Yeah.
couples will struggle to get pregnant. So if you think about yourselves as your friends,
Yeah.
out of 14 or 16 people, 2 of those people will struggle with fertility. And
That's something, to be honest, at that point, and I'll probably go back to how well we have this information out, because then there's a lot of social aspects and probably emotional turmoil that a lot of people have to handle later, because this was not anywhere in their thoughts that these are actually possibilities and how the numbers are, because you grow up in an environment where it looks like an obvious thing. And actually the parents made them very obvious, because what they'll tell us boys is avoid sleeping with girls will make them pregnant. And so what does that mean?
The same.
Sex equals to pregnancy. Now when someone else has to tell you that, oh, actually you can have it, and doesn't happen, I feel like that's some bit of struggle that I'll look back and say, how do we even frame that much earlier, because it has implications around how people need to handle this socially when this doesn't happen, either on the guy's side and on the lady's side.
Coincidentally, a lot of men and even society will not easily accept when it's male infertility. We've just had on our one of the episodes this coming out that the guy goes like, what? No sperm. There can be no sperm. Like it didn't even occur to the guy that there can be a possibility that there's no sperm. And this is usually very shocking if and when a man comes to have his tests. We really struggle to convince the couple, the male side, to come for the test. And I like to have the couple as men and female, male and female, because of the numbers, the statistics. So while the biggest cause of infertility will be tubal disorders, which are in women, coincidentally can be brought around by the men. A lot of the other issues are also from men and the sperm.
And even that whole realization that some of the causes of infertility actually from men, right? And it could be the same couple that some of these things happened. Is that a conversation that people have? It's probably not. Then and also other things around what are some of the factors around it, what are the odds around it. I feel like there's quite a lot that is not said from the parents, probably. For you can forgive them because they're coming from, it's something different as a mother or as a father to have certain conversations with your children when you've seen this as an obvious thing. Then
Actually,
how do you come to have a conversation like, actually it might not happen? I find like that could be some of the things that a lot of them don't talk about.
That would be interesting to have parents of their children who've struggled to conceive have these conversations as well, because I feel like also sometimes the parents might blame themselves or see it as part of like their problem, like especially if it's genetics and you go, my child cannot produce sperm and this is a genetics issue, yet he gets castigated. I'd be curious to talk to someone whose child has struggled to conceive, or who you've married them off and you're expecting grandchildren and then they don't come.
It would be an interesting conversation, because I think from my friends who have gone through, who are probably going through this or have gone through this, the biggest challenge I find like is the parents. Just for them they are trying to process it themselves, but the parents are processing probably on another level, because there's a whole bit of trying to explain. So they're trying to explain bit can go overboard. Part of that will be getting all manner of pastors to pray for this, get manner of herbs to try and sort this out. So there are a lot of other things which can be traumatizing to the group that is actually trying to get this resolved through other means, IVF and others. But I find like that conversation between the parents and this couple that are trying to get this would be a very interesting one, especially from the parents, around how understanding they can be. Although it would be good that parents now actually have that as a real possibility right from early stages. Then that can easily be processed later, because then actual decisions can be made around we actually are okay without having to go through this. Because then that push has other implications around what the society has drawn as the expectations. Because I mean, some of them will tell you they just want to wait maybe 2 years before they without infertility coming in. But there's always a push. Like, why?
Why
Why are we wasting time? We're waiting.
Even as we want to be grandparents.
Now it gets worse as the waiting continues over time.
Food for thought.
I'm
hoping that the audience will be sharing this with their parents also, because I know now there's quite a number of parents who are watching podcasts and things like that, so that we can start to think around how we even talk to couples who are trying to conceive. Even if you don't know that they're trying to conceive, it's a very weighty matter. And I find that a lot of my couples have been trying and they're not able to vocalize and say, we've been trying, but it's not been happening. It's a very difficult conversation to have.
Something else, I think it would be interesting also to have a conversation with some of the couples that you're working with around that social aspect of this. Because I find like it's the biggest kind of challenge, especially around what kind of pushes they're getting. Yes, from their peers, but I think from the parents. I find, at least for my friends who've gone through this, I think their parents, it seems like it's just heavy. I do have couples, and I mean even women coming after they separate, because this can be significant enough to make people break marriages. And they would come and say, how can we work around this treatment without other people knowing? And they're very conscious. Can I come for my scans very early before I go to work, because I don't want anyone to know? And they get to a positive pregnancy test and they still not wanting to let people know until very, sort of much later. Food for thought. I'll put that as a thing. But the reason why, because as a society, then I think some of these conversations are hard to have because there's a set trajectory that you grow up, do this. Like there's a staircase that all of us have to follow. You get married, then the next is children, the children grow, and all this. So it's confusing when that staircase suddenly the stairs are not there. So what now happens? How do you deal with it? And I guess most of the people who want to say like let's come in the morning. It's that whole process of stigma that comes around this. So talking about this even openly and actually maybe getting more people who have gone through this to talk about it
and
can
their
help.
Experiences,
because I find sometimes it's easy to say like 1 in 7, but actually when you've never seen them, because it still remains just a number. But now you need to put like how are people processing that are going through it themselves.
Coincidentally, 11%, so you have an 11% chance of getting pregnant a month, usually 11 to 15%. And I agree with you when I talk about numbers and statistics. I do find that even when I explain that, then suddenly people go like, it's less than 50%. Having grown up all your life being told, don't play with girls. And girls
like
don't
whenever you have sex with her, whenever you play with her, you touch her,
she's pregnant. So when I'm explaining this to couples in the clinic, they just go like, what do you mean? But
that we were told.
And all this time we've been taking contraception. I have girls who tell me, all this time I've been spending my whole life avoiding this pregnancy. If I knew that, I would probably have started earlier or done something about it earlier, whether they're preserving gametes, eggs and sperm. So it's actually very small. 85% of couples will conceive within the first year without any intervention from us. The other thing that catches people off guard is when then I tell them you have to have sexual intercourse 2 to 3 times a week every week. And the women just go like, sorry, what now? If you are like Dr. Muchiri, who is a gynecologist, when is this 2 to 3 times happening?
Yeah.
I work day and night and 24/7. I have this too much. And the guys go like, doctor, tell her.
Tell them.
This is what we have been saying. So the challenges around even how we frame and message versus what is actually happening on the ground. I once had a couple who were in different parts of the country, teachers, one by the coast and one in Kisumu. And they'd been together, married for 2 years. But they only meet during the school holidays, which is 3 months in a year.
Yeah.
And on those 3 months, she may not be ovulating or having an egg.
Yeah.
And it was such a surprise to them. And I was surprised that they were surprised, because I'm like, but how will we make the baby? You're in different parts of the country, and when you meet, there may or may not be any egg. And they conceived within 2 months after we had that discussion. But it still surprises me how that information and how we process, and back to what your doctors and your mothers don't tell you.
Yeah, and even of course you probably know this better. Like, it's not about daily.
Yes.
So again, it has implications if you're having
too much. There can be too much. People ask me, is there too much? And I'm like, yes.
So there are all these lines around what is the optimum. And I don't think people go into that conversation around the optimum. Which I guess you tell that to the patients that you work with. I think the other bit that just aligned with some of the bits that you've said is also just acknowledging all these other pieces that have come in our lives in terms of careers, how they influence some of these interactions that you've clearly highlighted, and how do we make sure that we communicate that quite well? Because remember, you've been told to push this side quite a bit, and there's this small bit that still bothers you, but it's a small bit around getting pregnant or getting your partner pregnant. But again, the time given to it might not be that, but it's not something that well communicated from the doctor. And because for you, remember, as a child, you're told when you touch her like this, she becomes pregnant. So you can't explain to me that you had sex 2 months ago and it didn't work.
I usually keep a very straight face when I get this kind of patients. I go like, sorry, when was the last intercourse? And the couples just look at each other and they're thinking, and they're like, he's been traveling. I mean, and this happens even where I work in the UK. The people are traveling. And they tell you, he lives in America and we meet when we can. And I'm like, wow, you're not trying. And they get very sad when I say it, but So thinking about this, sort of struggles. So you didn't get information about prepping. You just walked into... You just winged it. Basically.
Basically winged it. This is the way things go. You do this, then this will be the result. But I don't think anyone ever gives you this other dynamics around it. Like, there's a possibility of this. Because the reason why I'm talking about that, I find like it helps people process certain outcomes. Because when it's like telling me that when you just read, you pass exams, but no one tells you that there's a possibility that you might actually not pass. So how do you process that a bit? Because that has never been explained to people, that actually this is possible, that you might not. Both from... And that also informs why the social pressures come, because it's been seen as an obvious thing.
I'd like to address the audience just a little bit, is that this is a medical doctor.
Yes.
So I want to imagine how the rest of the population, if the medical doctor walked in with no prep at all.
Zero.
So imagine how the rest of the population is. And bringing that back to part of the work that you do in terms of access, giving information, having the right knowledge, and when to apply that knowledge. I think it's really... people assume that you're a doctor, so it will happen. And it doesn't work in that.
And actually, I would say it's worse when you have some knowledge, especially from the doctor side. It can be good or bad in equal measure, because there are a lot of assumptions made based on your understanding of this, but there are certain things humans always, you know all these possibilities, but you always imagine you're the exception. They're not for you.
Because it's not a problem. My problem.
No. There's a problem for others. Probably, a select, because you go through, especially medical school, you're told long distance truck drivers. There's a list of people at risk.
People at risk.
You see, like, I don't think I'm on this. I don't drive trucks. I should be fine. So it's a whole element around how do we break it down to this information, because then that might help people to process this.
One of the more not shocking, but one of the causes of tubal problems for women is smoking.
Yeah.
And smoking also affects testis and testicular production. But every time I've had this conversation with people, they go like, but women don't smoke. And I go like, but they do. But we don't talk about the effect of that and how it affects the tubes, and also toxins, the environment. There's stuff that is definitely happening that's making our fertility either look more pronounced, maybe we have more information are talking about it, or affecting gametes. We've recently come to the knowledge of sperm for men. So we used to say men can reproduce forever until they die. But we've recently had evidence to show that sperm also starts to deteriorate at the age of 40 for men. What do you think about that?
So this is, the interesting thing about that fact is, when information has been around for so long, and this has been demonstrated by our grandfathers, even though there are lots of confounders around it, because you'll be like, my grandfather had a child when maybe 70, 80. That's me, my grandfather. Yeah. So, but the other confounders, you don't know how the village used to work. The villages have mechanisms of sorting this thing out. So it could be that this person is 80s, but is the way things do happen. Like, other men come to visit
to
at
help.
night to help out. But it's never information that is shared. So it has been made obvious based on certain observations over time. But again, back to the ratios, because it would be like, but a friend of mine was 50 or 60, had it, but that might be an exception. But as you rightfully put it, the quality actually deteriorates over time. But the good thing is, probably the only positive thing is they're produced in millions.
Yes.
That's the positive thing, is produced in millions. So that probably gives that probability of, the chances of doing that. But still, without that probability, it's good to know, especially quality around speed and others, and what that means to the other factors, what that could be. But is that information out there? No. So it's almost so then social pressures keep on coming around. How do we get this out? Then blames start flying left, right, and center. And then the emotional torture of actually learning that is the situation. How is it to be processed? But so that I guess applies to those of us who are now on fourth floor. How we process that information.
Especially if you've delayed fertility. We have a 2.5 year now delay from when people used to get children, and the trajectory for the whole world is that we're delaying even further. And I remember talking at a women's health event once, and the ladies asked me, so Dr. Muchiri, you sound like you're advocating for young children to get pregnant. And I said, not really young. 25 to 30 is pretty mature, but not been impacted by all these other things. And they're not too young that they fall into teenage pregnancies where their bodies are not even mature yet to have pregnancies. And the moms were like, a 25-year-old pregnant.
Prime.
And it was shocking to see how like moms think 25-year-olds are like is too young.
And then some of them became mothers at 21.
This is the thing. I keep wondering, I'm like, but you were 21 when you had your children.
I think my mother must have been like maybe 20 or something.
But if you have this conversation, you should be like 20-year-old is too young.
My mother
That's
will
a
think,
baby.
Interesting, my mother will think differently because she's in the village. So villages things are different.
This is true.
For them, the earlier the better. But of course, there's this whole element around Now, our parents, even her, she's quite cognizant of there is a need for education. How do you get girls empowered and all that? So that has pushed, I think, a lot of them trying to see, no, first of all, stabilize in terms of your career before you think about ABC. And their fears are justified based on the experiences that I've seen in terms of girls or younger women who have made that decision and how that has turned out to be, especially around the socioeconomic side of things when you're looking at their careers and others. So it's quite a tricky balance around, yes, let me get this going, but then it means this ball has to drop, or I have to balance these two balls, then I have, which compromise the overall goal of the things that I want to achieve.
I want to talk a little bit about some things, especially now that we are in Nairobi.
Okay.
And I alluded to tubal disease causing 45 to 50% of infertility. Tubal disease here being tubes for the ladies.
Ladies, yeah.
And when I talk about sexually transmitted illnesses, I feel like people don't understand the magnitude of these things and what it does. Because if you're acquiring a sexually transmitted illness, chlamydia particularly, but also gonorrhea, the women don't get as much symptoms as the men. A guy who gets gonorrhea, you will know, because you will be on fire when you're literally
burning.
It is just burning, and you cannot stay at home with gonorrhea.
That's true.
But the women don't get as many symptoms. They might have a discharge of smell, and then that's it. But this stuff goes into the tubes, and the tubes will heal. They'll cause some inflammation and heal with blockage. And then someone is in their 30s or 40s and coming to have the brunt of fertility at the time when they're ready. And I often get asked, where did this come from? How did this happen? But I never had any symptoms. I don't know if it's something that you've had when, whether it's work-related or socially.
Yeah.
From a gynecologist perspective, I always feel like people are not understanding the gravity of multiple sexual partners and sexually transmitted illnesses.
Yeah. So definitely I've heard about this, but I think it's because I'll probably attribute it to this, at least from my experiences, the conversations I've had. I think it has been given a dichotomy of two things that people should avoid. HIV, pregnancy. So when then all you need to do is either tests or make sure that you have P2 around that. But that rules out a thousand other possibilities of what this could be. So in terms of how well we shared information, especially of chlamydia, and it's good you highlighted it because most cases are symptomatic to in women, which then has other implications up in the fallopian tubes. But is that information provided in such a clearer way? No. It's provided in terms of this happens here. I don't have a discharge, I don't have this, then that would be good. Then on the treatment side, so one of the things in the many years that I used to practice, I'll see is this stigma around, because once you have multiple partners, then you can't tell the partner this. So there's one person who has received the infection from the other. So one goes to seek care, one does not. So goes to, again, transmit this to others because of all these kind of things. So how do we normalize seeking care around this? And even when they come to facilities, how are we receptive enough to actually provide that care? Because, of course, how judgmental these spaces can be based on certain infections. So how that will be. Then for those of us who are doing health systems, how do we make it easier for people to access such kind of care? Because then that's why there's been a lot of talk about youth-friendly clinics and others, because how we've positioned this is, you need to go queue and have all this. How have we facilitated people to just have easy access to STI treatment? And even the medicines to be there, or even the diagnostic tools to be there for this to be detected. Or if it's syndromic treatment, how do we make sure that happens? So I think there's been a lot done on HIV or STIs around HIV, but I think there's still quite a lot of gaps around how we're treating this, but more so around how we share the information. Yeah.
I agree with you. A lot of youth-centered, but there's a whole population that's now no longer youth, people in their 30s, 40s, 50s. And like you rightly said, HIV pregnancy, that rings a bell. In fact, now HIV, I think, has even fallen off a bit.
There's
a whole generation who have no understanding of what HIV looked like. In our time, we had all this messaging everywhere and videos and pictures and stuff like that. So I do agree with you. It may be something for whoever is, sort of leading health systems in the country or wherever it is, for the messaging around this, especially for this sort of 25 to 40 group who may be considering conception in terms of what that means. That's very interesting. Yeah, because it is they probably talk about it in youth-friendly clinics.
But you know the bigger challenge that is, even after you have this conversation on the podcast, is someone sitting back and saying, but I never did all that, and yet I didn't get it. So I find like, because some of the be it friends or colleagues and acquaintances who've gone through these challenges, you get into self-blame of what is this that I did that led to this. Then you start ticking out like, oh, listen to Dr. Muchiri talking about this, but I didn't do that. I didn't get this. This I didn't. Been a good girl all my life. So what are you telling me? So there's a lot of, yes, this is one of the leading causes, but there are many others that could cause this, so that it doesn't become a point of, but I think this, there are people who should be suffering from this, not me, based on what they've been doing.
Genetics and chromosomes abnormalities are also quite, they're rare, but they can be quite distressing. Growing up and having a genetic abnormality that makes you not produce sperm. So there's something like that exists. So in terms of genetics, where you have something like XO, you would not, or XX, so the Y chromosome missing, then you would have no sperm or no eggs, or few or eggs, or no ovaries and things like that. And those are things that people don't know and they don't seek out. And it becomes a very difficult conversation to have when you're much older and discovering at that point, oh, I didn't even know I had this genetic condition.
Good. Let me throw you a question from the streets.
Yes.
Around, is there an element? Someone asked me this question, but I thought, I'll ask Dorcas, because I'm not the best placed in fertility. So around, what she explained is around sperm incompatibility. Like, is there a way in which this lady and this guy, but the way their sperm reacts to their ova, that's something she was explaining. Something like that. I'm like, okay, I don't have capacity to answer that question. That actually you can have a place where it's not infertility on the end of all the causes we've explained on both sides. Both of them have ova is coming, the sperm is coming, but never. When they meet, they don't happen.
I always say having a conversation. The sperm and the egg don't have a conversation.
They're having a conversation, but they're not agreeing.
They're not agreeing on the agenda.
Yes.
Yes, so there's an entity, and I'm not happy about what it's called, but it explains what it means, i.e. we have not found the causes for that.
Okay.
A couple who've been trying to conceive for 2 years with normal ovarian reserve, so eggs are being produced and the sperm looks on paper normal, and have been trying to conceive for more than 2 years. It's called unexplained infertility. How innovative.
Extremely innovative.
But what we found over time is that we can take the sperm and inject it directly into the egg. So this is part of assisted reproductive technologies, and that's called ICSI, intracytoplasmic sperm injection. So there are cases where we do that, and that becomes the solution. So you need the sperm to actually get into the egg, and fertilization happens.
Okay. Yes. I found that to be one of the interesting pieces, and especially what has not been talked about much, because it can be very confusing if someone goes in and finds the ova good, sperm good, tubes
open,
everything else. But then this bit of this conversation is not happening, and their agenda is not happening. So I find like that's one of the elements that has not been talked about quite a bit around how that could happen. I know again you'll say it's quite a small population,
but it's very distressing.
It's very distressing.
In fact, I find that more distressing because if I told you the tubes are blocked, I now have a reason why you're not conceiving, and we know how to overcome that. But if the tubes are open, eggs are fine, sperm is fine, and then I tell you there's no reason, but we are going to do this, and especially if you do get fertilization from ICSI, then everyone goes back and goes like, so what was the problem?
And then they'll be like, okay, so because the other question might come, so does it mean that I look for another partner?
And some people have done that,
but
and then found that match actually produces a child easier than this one where we're doing ICSI.
So those are questions from the streets. Streets have had questions.
The streets are very tough questions, and people don't imagine that we get tough questions like
I have a feeling.
And they also imagine that they are alone. Couples who are struggling to conceive a lot of times feel like they're by themselves, which is very skewed for me in my head because I do this every day. I have sometimes 6 or 7 couples a day who are consulting on fertility issues.
And you know, the interesting thing, and that's why it probably makes you be maybe not a good person to have this conversation, to have that conversation with the patient, because like for you've normalized it. You're like it's a normal conversation. But in this thing, someone walking around, having to walk that journey, they are literally alone. They have not had 7 conversations every day. This is their first conversation they're having to have with you. And so I feel like doctors, like you should treat that as every case is a unique case. Because for them, they have not, remember you've seen 7 patients today. For me, I have not in my life. I have to.
And everyone around me has gotten everyone.
All
other 6 couples who are my friends.
Well, some of them are complaining that they need to abort the next one.
Yes.
And then you're telling me that this?
There are many people.
Like what are you saying? So I think like if as a doctor you treat each case
as itself.
Like okay, I've seen 6 others. You tell me your story, because then it helps you maybe help them better instead of, because when it's obvious, like just relax. I've seen these tubes. This is probably the 100th tube I'm seeing. This will be fine. But it's not as straightforward as it will be fine. There are many other layers.
That's interesting conversation. Fertility specialists, please get into that conversation. And because yes, it's almost another example that I use is as an obstetrician. There are very many normal pregnancies that end well with no complications. But from an obstetrician's perspective, all pregnancies are abnormal.
Yes.
Because I get to see the abnormal every single day, many times in a day.
And you guys never talk about it.
Yes.
and I find that to be the processing, because processing fertility is layer 1. Layer 2 is miscarriages. So how do you, because from your end you've had so many, so handling this is usually quite heavy, and all that moves to delivering then around that, other things could happen around it. So how you as a doctor, you have conversations around this, that whole thing, and the more we talk about it probably helps other people process that as possibilities. Because if you don't have this conversation, then what happens? Because remember that time when you've had a miscarriage or something, you're alone.
At night usually.
But what doctors will tell you, 1 in 100. 1 in 100. So you mean I'm the one?
I'm the one. And why is it me? Why is it me that I'm one in 100?
So those are things that I feel we should do more better in terms of the information we share.
Because
our parents, for them, because they had children, obviously, and it was very obvious. But actually, the other bit they never tell you, and I don't know whether you've ever had conversations with your aunts and others. Like, yes, has 5, 6, 7 children. But never talked about miscarriages.
Never
talks about them.
and
And a
then they
lot
go
of them.
like, yeah,
A
they
lot
say,
of them had.
I lost 2 3, then this one came, then another one, and then
Yeah. But it's talked
you
like
never,
by the way.
yeah,
It's
as
like,
if like, you know, it happens,
it happens.
and some are lucky and some are not so lucky.
Yeah. So now, has it ever been talked in this context? And that actually that's a possibility.
Yeah.
But for them, you know, since they have 6-7 children,
They're just,
they had 4 miscarriages, but you know,
and it was just, you know, the other survived.
and here they are.
Yeah.
And thank God. But now, when this is the only one that you're working with, how do you process this? So I feel like that's something that maybe, if you ask, you back to your question around what my mother didn't tell me, those are some of the questions, and those are the things that we didn't talk about. Like, did you actually go through this? You did. How did you handle it? But I did this, but did you actually process it?
Yeah.
It's probably something that more and more parents should be talking about.
It's nice that you brought that up. We've had quite a number of ladies in older age on the podcast, and I'll keep that as one of the things to discuss with another older lady and ask, so did it happen and what did you do about it? But because, yes, I don't see that conversation happening. I've managed, being a girl, being around women who are talking to women who are getting married, and the conversations there do not feature anything about preparing for the pregnancy and even labor. Just the discussion that this can be painful and traumatic, and the women have it, but they don't talk about it. And this is another one, the miscarriage bit. That's very...
Yeah, it's something that people, you know, it's obvious. Like when you ask your mother, your aunt, and everyone else, they have these random stories like, oh, you know, between this and this, there was someone. But no one ever goes back like, okay, tell me about it. How did it happen? How did you handle it?
So we've touched on quite a bit of, sort of things around what doctors don't tell, what doctors and what mothers don't tell us about conceiving and fertility. And I like that you brought that in, because that was one of the things I wanted us to discuss. So getting miscarriages, preparing for pregnancy. Is there anything else? Or if you are in my position as a doctor, or remove mother and put father, tell our audience about fertility in terms of preparation. Like, do you feel like there are other things that we've still not been able to talk about?
Yeah, I think there are things, but I think people now are a little bit more open about what they're looking at. Let's say, the fertility bit, I think we've gone through the miscarriages. But the other bit is around, and I see a number of people struggling with this, is what happens when you guys change your mind. And that we agreed we're not going to have children, but you change your mind. Or we agreed that we're going to have children, but they change your mind.
Yeah.
Or we are going to have 10, but now we have 1. So all this conversation, people are having to go through it in terms of the preparation to getting into this journey, or even this whole thing about spacing, what that means, and others. So I think on the first element around getting the children is probably a little bit more, I think a lot of people see it as the obvious next step. But now, as things go over and over, there are other things that come in.
There are many other
in the process.
I usually think about like even the economics of getting children and sustaining them, which has become
it's a good family planning.
And people go like, I would not, we thought we would have 5, but now we are 1 is enough, thank you very much. And for IVF patients particularly, the cost of getting a child is immense, and you had all these hopes and thoughts, and then now it's £10,000 in UK money. It's a million Kenyan shillings or so to try and get a baby. And I know it's difficult, and we discuss this. We have counseling. We have to have counseling for all our couples. But this is also another conversation from, what it means, the cost of trying to get a child, or the cost of children and raising them.
But I think also there's a cost. But at least, so I've talked to older couples before on certain things that people don't talk about. On how did you decide? You have, because on the outside, the message is we decided to have one child. But actually now when you go back, they'll actually see a series of miscarriages afterwards. So there's a whole bit around, yes, we chose, I mean, to you, I'll tell you we chose to have one. But the reality is we actually have been trying for so long, but we got to a point and said, you know what? I think let's work with this.
Yeah.
So I think I found it to be, a lot of people found it uncomfortable, this question on asking, like, why don't you have more? Without understanding the other layers of the conversation. Like, I don't think they just have, in some cases, not that they actually just wanted to have one. There are other things that happened along the way. So there are these uncomfortable conversations that a lot of other people try to process. And I don't think anyone else prepares you to say, hey, we wanted to have 10.
But this is what happened.
This is what happened. And you don't have to replicate this to 10 other people because everyone will be like, how come you chose only to have one? So you can't give the economics problem because, you're a professor at Oxford,
And you have capacity to engage with this.
What are you telling us, Dr. Muchiri? So that also comes in and says, how do I, is there a way of actually just safely being in a safe space and say, this is what it is, but this is what I'm having. Yeah.
You bring to mind something interesting, secondary infertility.
Correct.
Again, something that people don't discuss. So for the audience, primary infertility is when you have been trying to conceive and have never had any pregnancy, including miscarriages. You don't have any pregnancy. And secondary infertility is coming up more and more, and it's even more shocking for someone who spontaneously conceives easily. And then when it comes to the next one, they're not being able to conceive. And that conversation, I'm not sure how many people have it. Even within IVF, we talk about a 30 to 50% chance of success when we do when we put an embryo back. And there are people who conceive on that. They're that 30 to 50% of that embryo that worked, and it was just first time. Then you have 5 embryos and you come back and the second one doesn't work. And then suddenly it's, what do you mean? How did it not work? Why did it not work? So for our audience, just to make it clear, you can also struggle with conceiving even though you have had a successful, easy, straightforward conception before that. And there are causes. I'd suggest people see gynecologists to do that, to investigate that. So this secondary infertility is something that even doctors and mothers don't talk about. What do you think?
Yeah, and I feel like it even gets more complex and confusing because it comes with a whole other layer of blame and others, because then people will start throwing back to tubal blockage and others without necessarily now going back to how can this be helped and sorted. And I feel like it's one of those things that a lot of people then struggle with to a certain extent. Can we talk about it more? Probably it helps. Again, back to the conversation earlier, you're alone. Remember, the others are going on. They are on number 5. And on 2, it's not coming through. So that's a conversation that I think we should have even more.
Right. Good. So one of the segments that we have towards the end of the podcast is I ask the guest on to leave a quote or something, anything, a sentence, a line, a thought, an idea for the next guest, and then we discuss that quote or idea on this, like now. Okay. So I'm going to give you a statement that was given by the previous guest and ask you what you think about it. We'll have a conversation and then you'll give me your quote that I will share with the next guest.
Okay, good.
So that one was quite interesting.
Okay.
It was that men, so I'm going to try, I'll probably paraphrase it. So women will wear makeup because men are visual and they like to see good things. And then men will lie to women because women like to hear certain things. And I've really paraphrased it. I'm sure he said it much, like in one smooth sweep sentence.
Okay. Yeah.
What do you think about that?
I think it points to how humans tailor their truths or their lies to who the audience is. So I'm looking at you. And so even before we come to the men and women, I'm looking at you. You're a doctor, this. There are certain things you want to hear as I'm an examiner. So I basically just tailor the story to what you want to hear or see based on what really pleases you or, makes you happy. So I feel like for how our society has been sort of structured and gendered, it's around how do we, and probably it's a fact in terms of how visual we are, then women have played along to literally give men what tickles them, which is vision, at least from what the speaker said. And then maybe then what men have responded to do, after realizing over time that actually if I say this, it works. It doesn't matter whether it's a fact or not. And then, they go ahead and do it. So it's around how the two are interacting. Interestingly, it's been happening for centuries. And people are happy with what that is.
It's not news.
It's not news. Yeah, and I'm sure everyone else will be looking at it and saying, that's been happening. How dramatic, but like, no, that has been happening. And a lot of them know it without necessarily voicing it out. But the problem is by voicing it, you might get some good bashing. So sometimes some things it's not safe to say, but it's a fact.
Yeah.
Okay.
So what is the one thing that you would be looking for me to tell the next guest about anything? It could be women's health, about your job, life, family, a quote, wisdom, anything.
I think, top of my head, and it probably, I think a number of my friends know this. One of the quotes that caught my head, and it never goes away, and every time I get to apply it to certain instances. So it's probably one of those series you watch, TV shows that you watch, then you get this very small quote, then you're like, let me rewind. What did this guy actually say? So I was watching this like more than 15 years ago, Prison Break, the TV show Prison Break. So this guy, Theodore Bagwell, says something about we are captives of our own identities, living in prisons of our own creation.
Oh,
We are captives of our own identities, living in prisons of our own creation. So basically, Dorcus is a doctor well achieved. There are certain things that you can't do or say based on that, even though you wish to say them. Okay? And Matiko is a male father, husband, this. So that becomes my identity. But at the same time, it ends up being my prison. Because there are certain things I can't do or say based on this package of Dr. Matiko, husband, father. Yeah. We're captives of our own identities, living in prisons of our own creation.
Wow. Well, that has been Filling the Gap podcast. We've left it on a very high note there. I'm sure the next guest will be curious to talk about that. I'm looking forward to having that conversation. Prisons of our own creation.
We're captives of our own identities, living in prisons of our own creation.
It makes me think about this filling the gap, like these gaps. Anyway, they've been created.
And actually it applies quite a bit. So if my identity is around my ability to provide, what happens? So that becomes my prison. Then I'm aspiring to actually live to it. My ability or my femininity is tied to my ability to have children. What happens when you don't? Because then it becomes a prison. So I usually find it to be a little bit deeper in a lot of senses that to a certain, you don't know, like it's not something that is very out there that you actually imprisoned within that identity. But when you think about it, like why can't you put on clothes in a certain way? There's a certain identity. Then you're like, oh, I wish to have dreadlocks. Like, okay, what will people think? What will this be in my position? How do people view this? So you find yourself literally restraining quite a lot of things that you can do because of your identity. We are prisons. We are captives of our own identities, living
the
in prisons of
prisons
our own
of our
creation.
own creation. And on that note, this has been Filling the Gap podcast, where we choose or have discussions on filling the gaps on what your doctor and your mama didn't tell you. Please feel free to get into the comments, start or keep this conversation going. I am curious to hear what you thought about this. And like, subscribe, share, give this to your friends, family, relatives, people who are struggling to conceive. And we will see you on the next episode. Thank you.